40-year-old female, status post MBC versus a pedestrian, polytrauma patient. You can't make this stuff up. So she has an existing left BKA that was crushed in the car accident. So she can't walk on her left side because she has no left leg anymore. C-section ×2, and this is important. She is a single parent who is the sole caretaker for a child with needs. Really complex social situation. I bring this case up because this was the first case that I did using CurvaFix. I sort of wrestled with, why did I use it? I can put screws in anything. I've been doing this for a while, blah, blah, blah. And so right proximal humerus fracture, multiple rib fractures, left proximal humerus fracture, left distal humerus fracture, interarticular comedy, standard polytrauma patient, and then a pelvic ring injury, which I don't know if the CT is going to play, but maybe it will, maybe it won't, nope. But she's got a right sacral fracture, a right superior pubic root with a parasymphyseal injury, so segmental. She's got the proximal humeri on both sides. She's got the interarticular distal humerus. She's got the flail test, and she's got the BKA without a prosthesis for her left lower extremity. The other scenario, the other issue was that she had to be early weight bearing. She won't get a new prosthesis for her left lower extremity for 4 weeks. We had some insurance stuff, and our prosthetic people came in, and they were going to make her a temporary one, but it was not going to be overnight is the problem. And so she, because of her social situation and her issues at home, one of the things that came up was the ability to have to weight bear through the right lower extremity, given that we were going to let her weight bear through the uppers, but how is she going to get around if she can't really mobilize on the right? And historically, I have not let patients weight bear immediately with traditional fixation of the pelvic ring. So now I've got this patient who I could put screws in, traditional screws, but she'll be toe touch or non-weight bearing because she can't be toe touch because she has no toes on the other side. And the other injuries that she has. So of course the first thing that gets done is the general surgeons fix her chest. Like that's the first priority, but that gets done first. And then we sort of start working on her, get her upper extremities done. And so like I said, for me, I in talking to my health system, trying to get these screws in, this to me was a very reasonable, very rational decision to put an implant in that would allow me to allow her to weight bear immediately on that side. And so the screw in the back, I know you guys have seen sort of pictures of this, so I'm not going to belabor this. You can see the tunnels, you can get the wire around the tunnels, you can direct it. So I got a transiliac screw all the way across, and then it came to her anterior column. Now this was, I said before, a superior pubic root with a parasymphyseal. So docking the screw in the symphysis or on the injury side may not provide enough stability. So the idea that I had here was, and you may have seen some of these x-rays already, is to take that guide wire and send it all the way across and dock the screw in the uninjured side, so at least had some stability of the parasymphyseal region, allowing me to have her weight bear early. The other interesting thing here is, for those who are non-believers, this is a 9.5 millimeter screw that's about to go in, not even a 7.5. So this is the large diameter screw that went into the anterior column, and I have CTs to show that it's contained all the way through. I allowed her to be immediate weight bearing post-operatively on that right leg while she was waiting for her left lower extremity prosthesis. This is her x-ray at 6 weeks. She's been full weight bearing, and I actually haven't seen her since her 6-week mark. So I have no idea what she's doing, but she hasn't come back, and she was able to go home right away. She was able to take care of a child. She went back to work a week after we discharged her. 48-year-old male, status post-fall. He's a transfer from an outside hospital. He's a BMI of 52. I'm not sure what he was doing up 18 feet, but he's got a BMI of 52. Past medical history is a little bit complicated. COPD, hypertension, AFib, and heart failure with an ejection fraction of 50%, which I thought was a good number, but I guess not. And so you can see his wonderful x-rays that we got that are not terribly helpful because of his body habitus and our x-ray technicians. But you can see the anterior column injury or the superior pubic root on the right. He's got a superior pubic root on the left that you can sort of make out on this image here. And he's got a right-sided sacral fracture, which I don't think the CT is going to play, but so he's got a posterior ring injury, bilateral anterior ring injury, and oh, it is going to play. There we go. So we've got a few different options for him. He's unable to mobilize. He's got some other non-surgical but medical issues as well. So we want to do upper sacral segment fixation in the back, and then I was trying to figure out, do I put an X-fix in the front, do I put an in-fix in the front, or do I do bilateral anterior column screws? He is not a kind of a human being that can be non-weight bearing for 6 weeks or 8 weeks waiting for his anterior column and his posterior segment to heal. And so, and you can see putting an X-fix on him with his pannus may not be the best idea since his pannus is outside the CT scanner or the CT image. And then the idea of an infix, I've done that before. I always worry about perforation of the abdomen in people who are this big, just avoiding kind of getting into the abdominal contents, which is a reported complication in this patient population. And so for him, we did bilateral anterior column screws and that posterior transiliac screw. I made him weight bearing immediately post-operatively. And this is him at 3 months. He's weight bearing fully. He's got no assisted devices. He hasn't done any PT, shockingly. His pain is 2 out of 10, but he's just taking over-the-counter medications. So again, one of these situations where I didn't think an external fixator was a great idea, and getting him weight bearing was critical, especially with his body habitus. So those are the 2 high energy cases I'm going to share, and then I have an acetabular fracture that was treated with CurvaFix. This is a 90-year-old male, status post-fall, transferred again from an outside hospital. He's been unable to bear weight on his right leg since his injury, and initially they were treating him like a femoral neck until they got a CAT scan. I'll show you the scan in a second. He's a community ambulator with a cane. He lives in senior living but lives independently, and he's been at the outside hospital for 4 days, unable to bear weight. The other reason he got transferred was he had a C2 fracture, which ultimately our neurosurgeon said was non-operative. So he's a non-operative C2 fracture, 4 days, bedbound. PT has attempted to get him out, but they haven't. So then he got transferred to our hospital, where you'll see the CT hopefully play in a second. It's very minimally displaced, but he's been unable to bear weight for 4 more days in our hospital with 3 attempted sessions of physical therapy. So this guy's sort of stuck. He's got ambulatory dysfunction. Sniffs are really not, they can't do anything because he can't bear weight, so they're having trouble sort of placing him. And so we talked about, all right, well, if we percutaneously fix his columns, I'll let him weight bear immediately and he can maybe go somewhere. The only issue here, and I don't have a problem putting in supine posterior column screws. I think it's a pain in the butt a little bit because you have to lift the leg up and put the screw in. So it's easier to go prone, which I don't have a problem doing either, except in his case, neurosurgery said you could go prone, but then you have to neuromonitor, which that just adds a layer of complexity that I'm not interested in, right? So like, I don't want to have to deal with neuromonitoring and whatnot. So, but I also didn't want to, I wanted to put a posterior column screw in him so I can mobilize him quickly. So put the anterior column screw in, and then instead of having to go prone, went supine through the gluteus medius pillar, and you saw Langdon's x-rays as well that showed this, but you're able to, which is challenging to do with a straight screw, I think, go from the gluteus medius pillar down the posterior column into the distal end of the fracture site. And so you can weave it around the articular surface, as you can see, and then position your screw. He's immediate weight bearing post-operatively, and he was discharged back to his senior assisted living facility, so what is his home, on post-operative day 2. He returned to clinic at 8 weeks, home, walking with a cane, also 2 out of 10 pain, mostly in his medial knee, and he's got no hip pain that he complains of.